We're gonna wait for a few minutes if it's possible.
Okay, tell me when I shall to begin.
Okay. So I'm gonna take a moment to actually introduce you to our participant. First of all, I want to thank you for being with us today, Dr. Ghada today. You are an audiovestibular specialist in health insurance, currently pursuing a doctorate of medicine in audiovestibular medicine. I'm not sure if I'm going to pronounce this correct.
Munafia University. Munafia University.
I apologize for my pronunciation.
No.
You have a master's from Cairo University. I think we have enough participants to actually start. I'll give you the floor again for.
Can I? Okay. To start now?
Please.
First, I'd like to thank Dr. Fargal and Dr. Solara so much for this kind of invitation. And I'd like to thank all participants. I shall talk about the enlarged vestibular aqueduct. First, to know abnormality, we shall first to know what is normal. To know if it is pathologically changed, what shall occur. First, development of endolymphatic sac and duct. As we know, otic pit is formed opposite to hindbrain in 24 days of gestation by invagination of surface ectoderm, which is then forming this invagination more deepen and causing formation of vesicle. This otic vesicle separated from surface ectoderm and sunk in underlying mesoderm. This vesicle will differentiate into different parts of our membranous labyrinth. It's anterior part forming cochlear duct, this posterolateral part forming utricle saccule and 3 semicircular canals, posteromedial part forming endolymphatic duct and sac appear here. And this is microscopic image of that. Endolymphatic duct and sac continue to grow postnatally until age of 3 or 4 years. This is membranous. Surrounding mesoderm will form covering bony labyrinth. The covering bony labyrinth starts wider than membranous labyrinth, not tightly encapsulate it. Begin to encapsulate by narrowing distance between both at 5th week of gestation. Vestibular aqueduct. Our ear is formed from bony and membranous labyrinth. Vestibular aqueduct is part of this bony labyrinth. Vestibular aqueduct, as here in this diagram, is inverted J shape or hockey stick appearance. This is vestibular aqueduct. Begin from vestibule and hook posteriorly or posteromedially to open in posterior cranial fossa by this wide opening. It is narrow bony canal, inverted J shape. Initial is parallel to common crus. Its first part is parallel to common crus. Then hook posteriorly at its narrowest portion, which is isthmus, and then broaden to include or to encapsulate the part of endolymphatic sac. This is vestibular aqueduct as bone. Membranous labyrinth is formed from, as appear here, from cochlear duct, utricle saccule, and 3 semicircular canals, and endolymphatic duct and sac appear here. Endolymphatic duct and sac is formed from. Duct is formed by confluence of utricular duct and saccular duct. Their union is, first part is broad, called sinus of endolymphatic duct, then taper gradually into its narrowest part, which is isthmus, here, in isthmus of vestibular aqueduct. And this is inverted J shape with an inverted J shaped vestibular aqueduct. Then duct tapers and beginning of endolymphatic sac appear. This is intraosseous portion of endolymphatic sac. And this is bony rim of end of vestibular aqueduct, which is called here aperture, and on CT scan it is called operculum. This is tapering of vestibular aqueduct, and this is part of extraosseous endolymphatic sac, which is covered by dura, not by bone. What is the function of endolymphatic sac? Endolymphatic sac main function is to preserve our endolymph from variable aspects. Its volume, its ionic composition, and its circulation within other parts of membranous labyrinth, which is necessary for normal hearing and balance. How this occurs, we will know later. Hearing loss in children. It is categorized into acquired and congenital. Our interest of inherited genetic causes of hearing loss in children, which may be syndromic or non-syndromic. Enlarged aqueduct may be either syndromic or non-syndromic. Gene implicated in hearing loss, our interest is gene called SLC26A4, which is gene located on long arm of chromosome 7 in region 3, subregion 1. This encodes certain protein, which is called bendrine. This bendrine is present in our body in thyroid, inner ear, and kidney. They also found it in other parts like airway, mammary gland, and liver. In the inner ear, bendrine is present in non-sensory epithelial cells, all over membranous labyrinth, in cochlea, in vestibular parts, in endolymphatic duct and sac. What is the role of bendrine in our inner ear? Bendrine acts as anion exchanger. What's the meaning of anion exchanger? I'd like to see this figure first. This figure showing endolymphatic component of different part of our membranous labyrinth. We can notice that in cochlea and in vestibular parts, pH is 7.5, equal in both, which is neutral or slightly alkaline, while endolymph in endolymphatic sac is shifted toward acidic, 6.7 up to 7.1, more acidic than pH of other endolymph of other parts. So this is kept by bendrine. This is difference is kept by bendrine. So to convert endolymph from our membranous labyrinth to endolymphatic sac and convert it from alkaline into acidic, or for its circulation from endolymphatic sac back to cochlea and the membranous labyrinth of vestibular parts, this need anion exchanger, which is active and need energy. This active pump is performed by chloride bicarbonate, the chloride bicarbonate pump. The bicarbonate is present intracellular to be excreted extracellularly or efflux extracellularly in exchange with chloride and the influx of chloride. This need energy and this need bendrine. So bendrine is critical for keeping pH regulation and for fluid reabsorption. Also, bendrine is found in kidney for have role in bicarbonate secretion, and in thyroid gland role in iodide transport. And this physiology we should know to know difference between endolymph in different part of our inner ear, membranous labyrinth. We can also notice that there is difference between endolymph of endolymphatic sac, that it is high sodium content in comparison to cochlea and vestibular system, and relatively low potassium content. So endolymph in endolymphatic sac in comparison to other parts of our membranous labyrinth characterized by higher sodium, lower potassium, lower pH, more acidic than cochlea and vestibular endolymph. This is controlled by what's called sodium, potassium, chloride co-transport, and aquaporine. Pathophysiology. What will do if bendrine is mutated, or gene is mutated and formed bendrine is malformed? Bendrine mutation and endolymphatic hydrops. The main insult is formation of endolymphatic hydrops and inflation of our membranous labyrinth. This is done by bendrine responsible for pH regulation. Now pH will not regulated and will still acidic in whole parts. This acidification of endolymph impair calcium channel, decrease calcium resorption, and the presence of calcium in large amount in endolymph, not intracellularly, decrease sensory transduction and cause degeneration of hair cells. Also, this acidification in either cochlea or vestibular endolymph decrease hydrogen ATPase function, which is responsible for our share in sodium absorption, entrance of sodium into cells. So sodium will exaggerate, or its amount will be increased in endolymph of other parts. As we noticed before, sodium only high in endolymph of endolymphatic sac. Other parts not that high. Lead to this increased sodium, lead to more absorption of water, lead to more endolymphatic hydrops, which our body try to resolve this by compensatory increase in sodium channel numbers, more than normal. Decreased sodium absorption lead to increased water secretion and decrease its absorption, lead to more hydrops, lead to stretch of inner ear epithelial cells, lost endocochlear potential with retarded growth of sensory organs and damage of stria vascularis. Dysfunction of epithelial fluid transport by bendrine and SLC26 formatation also lead to more hydrops and more fluid secretion and decreased absorption within cells. Even in some cases, scala media reach to 10 times its normal size. Bendrine mutation in vestibular parts lead to also acidic endolymph, increased acidity in endolymph of vestibular otolith organ, lead to formation of more otoconia in giant size, reaching 200 micrometer, while normal otoconia is 20 to 30 micrometer. And also exaggeration or increase and the deposition of calcium in endolymph more than intracellularly lead to degeneration of sensory cells in vestibular organ. This is another examples of genes included in non-syndromic sensory neural hearing loss. Enlarged vestibular aqueduct. Causes of malformation, what will cause enlarged aqueduct? As mentioned, mesoderm is not tightly encapsulated membranous labyrinth till 5th week of gestation. So stop of development before the 5th week lead to persistence of widening bony labyrinth. So narrowing failure theory, vestibular aqueduct first wide, then narrow by 5th week of gestation. Arrest of development lead to EVA. Second speculation is apparent development of duct and sac later in fetal and postnatal life. Third speculation is piled theory, which in contrary suppose that our bony labyrinths continue to grow rather than arrest of development. So it's continue to grow postnatally, leading to more widening of vestibular aqueduct. As we know, vestibular aqueduct continue normally to grow up to 3 or 4 years of age. Mechanism of hearing loss with EVA. First speculation. Now we have wide bony canal. As we know from audiology impedance, narrow bony canal protect delicate organs from transmission of pressure. When canal is narrow and thin, this prevents transmission of pressure change of CSF to membranous labyrinth. Here, canal is wide, so its impedance for transmission of pressure waves decrease. So pressure waves will pass from CSF or intracranial pressure back to membranous labyrinth. So first speculation of hearing loss is rapid change of intracranial pressure will be transmitted to endolymphatic sac, which is present between dura mater layers, back to endolymphatic duct, back to membranous labyrinth. Either pressure itself cause injury to sensory cells or lead to reflux of acidic endolymph suddenly to sensory cells in vestibular system and vestibular membranous labyrinth and the cochlear duct. So injury come by two ways: reflux of hyperosmotic endolymph or transmission of pressure waves to sensory cells, which is not sensitized to stay against this pressure change. Second speculation, as mentioned, bendrine is present in non-sensory epithelium all over the system. So it is present in cochlea, vestibular, and endolymphatic sac. Its mutation in different part of this system making membranous labyrinth fragile, causing rupture or tears in membranous labyrinth, causing mixture of endoperilymph, which is harmful on hair cells. Third speculation what mentioned is CSF pressure change transmitted directly through white canal to hair cells. Another cause of hearing loss is incidence of round window abnormality. Coexistence of multiple anomalies in our system may cause hearing loss. Co-persistence of round window anomaly is reported with enlarged vestibular aqueduct predisposed to hearing loss by perilymphatic fistula formation. Also by endolymphatic hydrox. These are speculations why patient with EVA can be presented with hearing loss. Clinical presentation. Clinical presentation of EVA patient presented to our clinic may present in different forms, either sensory neural hearing loss, either conductive or mixed hearing loss, or vertigo. Sensory neural hearing loss with EVA characteristics, it is predisposed by minor head trauma. Duct, as mentioned, is large. So